Thank you for considering me for this debate. It is a very enjoyable talk for me because I absolutely believe that OCTA is a must for retina practice. I thought that was a very solemn and sober debate, the first one, so I plan to change that. So I hope nobody gets offended, although my intention is to offend. So this is going to be an image-based debate. My images will speak for themselves. There is no debate here, just scientists and non-scientists, and since the subject is science, the non-scientists don't get to vote. So what's in it for you? It just takes a few extra seconds. It's just there on the machine, same machine, one step extra, no injection, no dye, no retching patient and other patients getting scared about what is happening to him, and there are no contraindications. What can it do? You're going to find lurking membranes. Features of activity also you can find. It lays bare ischemia, inner retinal, outer retinal, choriocapillaris, choroid, and I sincerely think scan ek seek anek. So would you believe that this patient has a CNVM? Let me show you. So this patient, most of us will diagnose as a CSC. This is a unholy mess on the FA because it's a stippled fluorescence, and probably because of CSC you see a descending gravitational tract. But look at this. I found a membrane here, and I would definitely consider anti-VEGF for this patient, which corresponds to this membrane corresponds to a hyper-reflective double layer sign. So look at this wonderful image. I can find a network. I don't need an FA or an ICG. I found this network in a young patient of pachychoroid neovasculopathy. So if you recognize this picture, it's very typical of angioid streaks. These hemorrhages are possible even if there are Brooks membrane ruptures. I did find a beautiful neovascular membrane in a case of angioid streaks. So would you believe that this patient has a CNVM? You can see a perifoveal graying. You seem to think that this is just pre-proliferative mactel. You see this FA, another unholy mess of leakage, masking whatever leakage may be there from a CNV. But look at this image where I've segmented it properly in the subretinal space, and you find this choroidal neovascular membrane. This is another very interesting case. This is a case where we actually found a RAP and a PCV lesion. Let me just show you. This is the hotspot on the ICGA. This is the RP aperture sign, and this is a double layer sign along with a tall peaked PED. And if you see this OCTA, it's showing the RAP lesion. And once it comes to this tall peak PED, it's also showing polyps, so many of them. And it was a joy to diagnose a RAP as well as a PCV lesion. So this is another case. My opponent may say polyps are not visible, but I can find polyps on OCTA. This is the ICGA, and here you see this beautiful polypoidal lesions corresponding exactly to the ICGA, showing the polyps. So this is a very interesting case of cuticular drusen. I would not expect anybody to find a membrane, but I did because I have OCTA. So this is the AF showing a lot of hyper AF material. You can see these vitaliform lesions in the subretinal space. This is starry sky appearance. Where can you see a CNVM? You can't. But I found 3 small membranes which is not masked by FFA or ICGA because of the vitaliform lesions. My OCTA can pierce through all that nonsense and find me a membrane. So this I diagnosed as a case of cuticular drusen complicated by acquired vitaliform lesions and CNVMs. So look at this slide. Are you telling me honestly that you will do an ICGA at every visit for this patient when I can show you how nicely this big lesion has resolved with one injection of aflibercept? So what I'm trying to say is, so many times we not only inject unnecessarily in the arm, but we also inject unnecessarily in the eye. So look at this patient. This is a case of amphigenous choroiditis, which I diagnosed on the OCT, no doubt. But look at this big choriocapillaris flow voids, making a diagnosis of choriocapillaritis. It's clinching it. And this shape is exactly like what I found on the ICGA. So for what joy do I need an invasive angiography when I am finding this beautiful flow void on a non-invasive angiography? So if you have money and you're contemplating angiography for your practice, OCTA is better than ICG angiography because most of us have FA. So what happens when you know more, when you see more? You know more, you see more, you read more, you write more. And these are my 3 publications in ophthalmology retina based solely on my OCTA findings. And you have to agree with me that these are absolutely stunning to look at, and a thing of beauty is a joy forever.